welcome to all point-of-care ultrasound lovers. Today we will be discussing the pearls and pitfalls of the Lungpoint. Before we go into depth, let me first introduce my co-host, Chris Walpott.
Hello, everyone, and thank you, Ruben. I'm very glad to be part of this very first BEUS video, and thank you for having me.
You're an emergency physician with a broad experience abroad also.
Yes, I've worked in a couple of places. I've worked in Belgium, UK, South Africa, and I'm currently doing my ultrasound fellowship in Christchurch, New Zealand.
My name is Ruben Hazendonk. I'm also an emergency physician. I'm working in Zolk Hospital in Ghent, in Belgium. I'm the current president of the BEUS, which is the Belgian Emergency Ultrasound Society. And BEUS propagates point-of-care ultrasound, but also ensures quality of care by monitoring the skill set of clinicians. And Chris and I will kick off with our very first episode of a monthly series on point-of-care ultrasound on our BEUS YouTube channel. Let's get straight to it.
Yes, because we know ED physicians have a rather short time span. Let's go.
Yeah, as a really brief intro, the sensitivity for pneumothorax on ultrasound is fantastic, ranging from 86 to 99%, depending on the quoted study.
Which is a lot higher than the sensitivity of a supine chest X-ray, which we know is only about 50%.
Yeah, well, we won't go over all the theory and practicalities for ultrasound diagnosis of a pneumothorax and expect our viewers to know the term lung sliding and know how to look for it.
In short, I think it's a movement of the visceral pleura which contacts the parietal pleura and can be described as shimmering, sliding, glimmering of the pleural line.
Yeah, indeed. And this sliding line is what you expect in a healthy lung. So as you can see here, it's moving back and forth with respiration, and the shimmering is an effect created by micro droplets of water between the two pleuras.
Good, man. And you can use any probe, I think, to detect this pneumothorax, provided that you adjust your settings. However, if I want to find the lung point, I think I would go for the linear probe. How about you, Ruben?
Yeah, I absolutely agree. You will see more detail and you're not looking for deeper structures.
So let's have a look at what we're talking about when we mention lung points.
Yeah, sure. Let's start off with an additional normal image you can see right here. So this is normal lung sliding in the healthy lung. So you have the two ribs, and just beneath it, you have the parietal pleura and the visceral pleura sliding against each other. So what we are going to look for is in a patient with pneumothorax, because here, in contrast, when your patient is supine on the stretcher, the lung will not be in contact with the anterior thoracic wall, as you can see.
And so when you put your probe on that anterior thoracic wall, you will not see sliding. You'll just see a static line. It's the absence of lung sliding. Um, you can only visualize basically the inner lining of that thoracic wall or that parietal pleura. In the right clinical setting, I think this is quite indicative for having a pneumothorax.
Yeah, absolutely. But that's also the issue. If there is lung sliding, you can absolutely rule out a pneumothorax with a negative predictive value of 100%. But in the absence of lung sliding, well, it doesn't mean that you're sure that there's a pneumothorax. For example, pleurodysys, blebs, or fibrotic lung diseases can alter the movement of the pleural lining.
Yeah, and as well, I think in main stem intubation and severe consolidation and some other inflammatory states of the lung, you can have the same.
So here in this image, you can see that there is no lung sliding. But again, this is not specific enough to rule in a pneumothorax, and that's where the lung point comes into show. Of course, we will look for lung sliding in the sagittal plane, and we'll look for it in different rib spaces. And as you can see here, there is no lung sliding. Going down, you might find a spot there where there is lung sliding, and then you can actually rotate your probe and look for the transition points, as you can see here. So
Right
lung
there,
sliding
yeah.
on the left, but no sliding on the right.
Yeah, exactly. And that's what you're looking for, right? You're looking for that separation point where some of the pleura moves with respiration of your patient.
In this CT image, you can actually see which point you're trying to visualize. So at this point, you want to have your probe. And here are some other nice examples of a lung point. So again, nice sliding on the left, no sliding on the right. One more example, nice sliding on the left, but no sliding on the right. And one more additional image, here it's the opposite, so you see lung sliding on the right, but no sliding on the left.
And this is great because if you have this lung point, then you're 100% specific and predictive that you have a pneumothorax, isn't it?
Yeah, as mentioned, of course, pleurodesis, etc., will result in absence of pleural sliding, but you will not find this moving lung point since the pleural adhesions are static. So that means that the transition point is also static and not vividly moving with respiration, as you can see in this image, for example.
And I think with that in mind, looking for a lung point is quite a game changer. It's important to mention though, sometimes it's not easy to find.
Yeah, true. I mean, we're not able to find a lung point in all patients with a pneumothorax. You will not see it in up to a quarter of the patients with a pneumothorax, especially with large pneumothoraces where the lung is completely collapsed and there's just globally absent sliding everywhere.
The site where you find your lung point can also be an indicator as to the size of the pneumothorax. Obviously, the more lateral you find your lung point, the bigger your pneumothorax is gonna be. Is there any pitfalls that we should mention?
Additionally, for example, a lung contusion can also mimic these kind of images. However, check for B-lines and for a lung pulse in the contusion zone, since both will help you distinguish and differentiate a contusion from a pneumothorax.
Hmm. And also, evidently, the interface where the lung touches the heart or the lung and the diaphragm interact, there may be an image that looks similar to a lung point. But if you're not sure, just zoom out of these images, and you'll find the significant structures in greater depth.
Yeah, yeah. Well, good point. Not a lung point.
Good play of words, Ruben.
Yeah, yeah, I know. So one more thing that can be confusing is a combination of a pneumothorax with a hemothorax. Here you will also find a transition between two distinct zones on your image, but here you will not have A nor B lines, and you will encounter an anechoic or black space in the dependent regions of the lung. But all right, we said we would keep it short, so let's round up with some take-home messages. I think very important to know is that the absence of lung sliding alone is not specific enough to rule in a pneumothorax.
And demonstrating a lung point is 100% specific and predictive of pneumothorax. It just can be a little bit hard to find if it's a very large pneumothorax.
Also, be careful around the borders of the heart and the diaphragm to avoid false positives. You can find more info on BEUS Belgium. That's BEUS, B-E-U-S, Belgium.org. All right, that's it, folks. Thanks, Chris, for helping us out with this nice topic.
Thank you, Ruben. It was my pleasure.
Yeah, and to all our listeners and viewers, see you all next month on a new episode of our BEUS channel. And don't forget to like and subscribe and spread the word.